for our ANZONA webinar, and apologies that we had a technical issue last time we tried to run it. Also, welcome to the people that will be watching this in future and joining in at a later stage. I'm Wendy Dukerism. I'm current president of ANZONA. We have Megan White also with us, who's our immediate past president of ANZONA. And what we're going to be talking today is about the competency framework that our committee on ANZONA has developed for orthopaedic specialty competencies. Something that is just phase one of this, and this is our first go at publishing it as well. There's further work to do, and we'll be talking about that as to where we go from here. But it did get launched after being endorsed by our ANZONA committee. It was launched at our ANZONA conference in Perth late last year, which is good. Before we make a little bit of a start on going through some of the parts of competency and the document, just wanted to give a little bit of background information. First of all, I suppose the question that comes up quite a lot, and it's something that they debate quite a bit in the academic fields, is what actually is competence. I mean, that could be a whole PhD in itself, and I'm not going to go into too much depth. Oh, let's just flip back. There we go. But it's a whole mixture of things that make up. Okay, I hope those slides work. I'll try it this way this time, and hopefully it'll stay up on the screen and we don't have too many gremlins. Yeah, basically with the competence, it's so much more than skills, and quite often when we talk about competence in nursing and within nursing specialties, a lot of nurses tend to think very skills based, like they want pretty much a sign off list, you know, like I want a science of attraction, I want neurovascular obs, and they get very, very focused on the skills. What we've done is looking at this competency document is realise that, first of all, orthopaedic nursing is much more than just the clinical part. There's a whole lot of variety of roles coming, you know, within that competence and our roles as orthopaedic nurses. And what we're trying to do is make it so much more than skills. For some of us who have been nursing a little bit longer, we will remember that the way that we used to be signed off for competence was C3, D3. You know, if we needed to be signed off for female catheterisation, for example, I'd go in and watch another nurse 3 times. I'd practice it with someone 3 times and have someone supervising me. And finally, when I'd done it 3 times more, I was signed off and it was all decided that I was competent at catheterising females. But it was very, very much skills-based that we were looking at. We weren't looking at the knowledge behind it. We weren't looking at the reason that that person was needing catheterising. We weren't looking at, is this the best option for this patient? It really was a physical skill that I was being signed off for. So when we're looking at competence, we're looking at much broader as knowledge from experience acquired in the inherent skills that we have, motivation and attitude, because that's a big part of, you know, what makes a really, really good nurse, and our knowledge through education. And it's when we combine all of those things. Oh, I definitely have gremlins here on the screen. When we combine all of those things, that's really what comes down to competence, and that's what we've tried to capture within the document. Now, I'm not even touching this, so I don't know why it sort of flicked through there. Another way to have a little look at it, and this is not a nursing specific model, this is another model that I found that was Right, I might just get Paul back for a second because I think we've just got a couple of issues with
Yeah,
things that are coming
the
up
setting
on the
changed. I'm not
screen
sure
as well.
why. We didn't click on anything, so hopefully that
No,
should be back
no.
now. Yeah.
Okay, and Megan's coming back on. She had difficulty there as well. So just back to where we were up to. First of all, we've got unconscious incompetence when we don't know what we don't know. We're not even aware of that. Then we move into the next phase, which is we're conscious of what we don't know, and it's that conscious incompetence. Um, as far as knowing the things that we don't know, but knowing that we need to build on that as well. Going further up, suddenly we're conscious of our competence, so we know what we're supposed to be doing, and we're thinking about what we're supposed to be doing. And then even at a higher level, we then move into the unconscious competence, whereas we don't even have to think about it. Okay, we're just working on our intuition, our knowledge, all of our experience, not having to think about it, but we've moved into that higher level of the unconscious competence. Okay, so when we had a look at the ANZONA competencies, keeping a lot of these things in mind, one of the things, and I'll just go back to that what, how, and why, and because I think that's a really good illustration of some of the things that we're aiming to do. And I'm just going to give you a very simplistic example of that as far as competence goes. So you've got someone, we're going into a clinical area here, they've read on a medication chart, someone's due for something, they've read the name of the medication that's on there. So that's the what. They're already in that what phase of the circle. First of all, it's having the knowledge that we need to bring in at this stage is the name of the drug, the knowledge of what it is, the knowledge of, the reason that the person's taking that drug. If we build on that a little bit further, we know that, for example, that's an antihypertensive that we're giving to them. Someone thinking it through a little bit more will think about checking what their blood pressure is doing. Okay, I know that that's an antihypertensive that's going to drop their blood pressure. So it's having that knowledge and also experience to know that we need to be checking their blood pressure. Say, for example, they have a little look on their observation chart. They've noticed that they've had quite a trend of low blood pressure. So again, that's using that knowledge and experience and then starting to bring in problem solving as well as to blood pressure's already low. Do I really want to be giving a medication that's dropping the blood pressure? Bringing in that problem solving to withhold that medication. Communication also comes in as part of this scenario as well, because we now know we need to liaise with the medical staff, and we need to, from a junior staff member, I need to liaise with my coordinator and not give that medication and not do anything about it. But my communication part of that is something that I want to have a little look at doing. So much more than a skill, we've already gone through knowledge, experience, problem solving, communication, and also critical thinking as to, right, what do we do about this situation now? Do we just leave the W on the medication chart, or do I follow this up a little bit further? And again, someone with a bit more experience may know, right, if I give that medication and I'm going to be getting that patient up to walk for the first time out of bed, there's a big risk of that person hitting the deck. So bringing in that experience and that problem solving as well. Someone at even a higher level as far as their competence will go is maybe having a look and saying, okay, how long has this patient's blood pressure been low for? How long have they been in the antihypertensive? They're having a whole lot of falls at home at the moment. Let's look at this and let's problem solve the bigger picture. So just straight from a name of a medication on a medication chart, there's a whole lot of those different processes we go through and not just a skill. Okay. Another really common question that we've had since the framework has come out is, how does it fit in with what we need to do with APRA? So in Australia, we've already got the NMBA standards of practice for nurses. Over in New Zealand, again, the Council of Nurses over there have their standards of practice. And what we're not trying not to do is actually replace those standards of practice that are already there. But what we're doing is realising that the APRA or the NMBA, the New Zealand ones, they're actually a minimum standard of practice for what they expect for our nursing staff. And we're not aiming for a minimum. What we're doing is we're trying to build on top of that minimum that already underpins all of the care. Like we always need to be practicing in accordance with those standards of practice, but we're then wanting to build on the top as to someone who's in an orthopaedic specialty area that's being looked after, a nurse with experience. What are they doing that's above and beyond what is just our minimum standards of practice? Okay, and again, it's also tricky just to take one of those standards of practice and just say, well, look, this is what we want to do, because what some nurses may not be aware of is there's one standard of practice in Australia for an enrolled nurse. There's another standards of practice for our RNs, and again, there's a third document for our nurse practitioners. And we were trying to get a document that encompasses ENs, RNs, nurse practitioners as well. So really, scope of competencies, it's starting from nurses that are new to our specialty, so that we're looking at that, right through to, we're very, very lucky in Australia here to have some nurses, orthopaedic nurses that are working at a really high level of practice. You know, they're on the Australian committee that came out with the knee standards last year. We were lucky to have one of our ANZONA members, Leslie, representing us as nurses for that as well. They're coming out with hip fracture guidelines. They're working on a global level to represent us as orthopaedic nurses. And we were looking at a framework that would cover that as well. We've based it, the what, the how and the why as to how we've based it. I think I've told you a little bit about the how, but another way that we've looked at the how is that International Council of Nurses had a competency framework for nurse specialty, nurse specialists, and we've used that framework to adapt it and to develop our own. And really, the big aim is to differentiate us as orthopaedic specialty nurses. What is it that people are getting as better care from us because of our knowledge and experience? When you have a look at the document, and for those who are not familiar with it, it is on our ANZONA Net webpage, right on the front page. You can click through and get to the document. One thing I will say, and Megan's about to go through some of the elements of the document with you, it's not meant as a start to finish document. Okay, we've got a whole lot of different domains that we're looking at. And what it's meant is that you pick out the key areas that are the most relevant to the area that you need addressing. Okay, so if you're a brand new nurse that's very new to orthopaedic specialty, the areas that you may have be most pertinent to you is looking at your assessment and planning of care. So someone that's already a nurse practitioner and has been, you know, or a very experienced orthopaedic nurse who's been working for a while, we wouldn't expect them to have to prove how they are in their assessment and planning of care. However, the leadership part of the document might be an area that's much more pertinent to them to have a little look at. Okay, so it's not meant as a start and a finish document. It's meant as a document that you can pick the parts out of it that are most particular to your level. And quite often under the domains, we've started with the more basic things and we've worked up to, you know, things that are a lot more complex as we go within that competency standard. Yeah, for example, a junior nurse, even within leadership, what we may expect from them as leadership while is identifying what's wrong with your patient and knowing who to tell. Okay, so that we want them to come up to a nurse, the person coordinating the ward or someone with more experience and say, look, I know something's not right. I don't know what it is. I'm not quite sure what I should do from here, but I know that I need to tell you. Okay, and that's them showing leadership and also clinical problem solving. Whereas someone that was a lot more advanced, then we're expecting, you know, a much more advanced reaction to that situation from them as well. Right, what I'll do is I will pass over to Megan, and Megan's going to go through some of those standards with you. Hopefully she's got her sound.
Okay, thank you, Wendy. Can you hear me okay?
I can. I'll bring the slide up to where you are. That's it.
Okay, thank you. Because I just won't be able to access the slide. Okay, so part of the competency framework was a group of us kept meeting up face to face, and the discussion was on the table for some time. So what we just wanted to really look at was looking at providing a framework for the orthopaedic setting and to really develop and deliver the care for the orthopaedic patients. We also wanted to promote and support specialist orthopaedic nursing practice. I mean, with a lot of wards, general surgical wards, it was a great opportunity to really define what the orthopaedic nurse is and what role we play in the overall care for our patients. We also wanted to look at what best care was available to maximise our patient outcomes and look at a lot of practice progression as well. And it was, as Wendy's explained, that novice to expert. So a lot of the times as you work your way through the competency, you'll notice that, you won't meet all the competence, like all the criteria, but it's something that you can work towards as well. Sorry, just waiting for the next slide to load. So our original aim was to have two booklets. So the first being the competency and then the second being the clinical elements. Because I guess a lot of nurses with a lot of the clinical elements, like your traction, your neuro. Um, but as a group, we felt we had to approach the competency. And as orthopedic nurses, we are in a variety of roles, whether it be acute in the rehab setting, looking after spinal injuries, which is very specialised, pediatric departments, outpatient settings or your ambulatory care, which is growing, operating community care, general practitioner nurses, university practice. So we knew that we had to incorporate quite a large variety of roles for the orthopaedic nurse. We also looking at, the two conditions that we all are looking after too, the fractures, injuries, dislocation. We've got specialised arthroplasty centres, infections, patients also in the community with chronic musculoskeletal disease or specialised musculoskeletal tumours as well. So it was quite a challenge to try and cover all these elements. So we are a very unique group with specialist skills, specialist knowledge. We wanted to keep up to date with latest technology and really look at changing our practice with a lot of new initiative developments. So with the principles, I mean, the whole purpose of this document really was to define us as orthopedic nurses in our best practice, differentiating orthopedic nursing practice, and we really wanted to empower the orthopedic nurses, so nurses that are working in general surgical wards to have that orthopedic identity for them as well. We also wanted the group ANZONA to help and assist in influence practice and policy as well, and advocating for excellence in orthopedic practice for our nurses as well as our patients. With the philosophy of ANZONA, we believe specialty of orthopaedic nursing should set forth the highest quality of musculoskeletal care by promoting excellence in research, education and nursing practice in a range of cultural, community and healthcare settings. So these were all our aims, and these were all in the back of our minds as we were developing these as a group. And this is also the ANZONA mission statement as well. So again, just the development and supporting our orthopaedic nurses and patients with skeletal conditions. So then we went through and started going back and forth, and as I said, meeting up several times to look at what competencies we wanted. So the first competency was the legal, ethical practice and accountability. So this was just making sure that we were practicing within the relevant legislation and regulations. And just also to really promote an orthopaedic specialist that they do consider any local international standards. And as Wendy was saying, we've had representation on national and international standards. I mean, with all the groups that make up ANZONA, with the New South Wales, South Australia, Queensland, Western Australia, etc., Northern Territory, and New Zealand, we're all coming together and we're representing on our local committees and representing on our state committees as well to really have that present at the best practice standards and developing policies within those areas. The standard 2 was the assessment and planning of. Again, it was gathering accurate and relevant objective and subjective data, demonstrating the knowledge of the generalist assessment tools, but really assisting in that clinical judgment and decision making. Also looking at organising and analysing data and thinking about the assessment, neurovascular status, risk assessment for your DVTs, your pressure injuries or any infection as well. And then again about a priority, what we as orthopedic nurses do around our assessment of care. And the third, our implementation and evaluation of care. So making sure that we as orthopedic and orthopedic specific nursing care consistent again organisational standards, policies and procedures. Also consulting and partners with their significant others and health team members to plan and help evaluate progress towards outcomes. And responds appropriately and time-changing situations. And this is a lot around leadership and really the care that many nurses do as well. The competency 4 was around communication and teamwork. So just looking at the different initiations, develop relationships, using a range of communication and interpersonal skills. Just making communication is clear, consistent and accurate. Considers the views and needs of our patients because as we know we are advocates for our patients. And just looking at effective communication between the various orthopaedic settings and the different stages in the care journey for individuals with musculoskeletal injuries. So when patients are transitioning from to either rehab or back into the setting. And the last one was leadership because as we know we want to promote all orthopaedic nurses as leaders, sorry. So again, that affiliation and actively participating with specialty orthopaedic nurses, interest groups, priorities of workload, clearly the contributions and expectations required members, adopting that leadership style and approaches to situations specific to orthopaedic specialty practice as well. And orthopaedic nurses acting as resource personnel, not only for the patients, but for each other as well. So, role modeling and how we want the next generation or younger orthopaedic nurses to interact with patients and giving the empowered work based from the proficient scale, so novice to expert. We'll read through the competencies. You may not reach them all. Gives you direction and helps really establish our practice as orthopaedic nurses. Wendy, did you have anything else to add?
Just turning my audio back on then. Thanks for that, Megan. Not too much else to add there, just really, and this is preaching to the converted, but this was a situation I heard about the other day that made me think about how important things like this framework is. And it was of a lady that had a knee replacement done a couple of months ago. Post-operatively, she had cardiac arrhythmias. So instead of going back to her orthopaedic specialty ward that she was going to, she was transferred over to a cardiac ward. Now, the cardiac nurses do a fantastic job of what they do, and they're certainly a lot more competent than me in managing the arrhythmia. But unfortunately, while she was in that ward, the knee that had just been replaced, the post-op care pretty much got forgotten about. They were quite nervous about moving her. They were moving her knee. She was actually well enough to start getting up and start getting moving around on the same time frame that she would have had she been in an orthopaedic ward. But due to their nervousness, they didn't understand the importance of getting flexion back into the knee and all those sort of bits and pieces. So here she is a couple of months down the track with a knee that's not flexing. She's needing to go back in for manipulation under anaesthetic, all sorts of bits and pieces like that. That's not having a go at the nurses on that cardiac ward, because they certainly did what they did for her very well. But really what it is it's emphasising that body of knowledge and experience and competence that orthopaedic specialty nurses have, and knowing what was really important that was missed out in those first few days for her. So what we're just trying to do is get those sort of bits and pieces down on paper, just to show the importance of having orthopaedic specialty nurses looking after our orthopaedic patients, so that we are protecting our specialty with that as well. Yes, I suppose that's all I really wanted to add, except for the where to from here. And certainly the clinical elements part of the document is the next part that ANZONA is going to try and have a little look at. Trying to capture that, because we are so many different and varied roles through so many different settings, and we're also right from paediatric right through to end of life, basically, with our orthopaedic roles. Trying to capture all of those clinical elements is going to be quite a big job. and ANZONA is coming up with planning at the moment as to how we're going to do that. It won't be a skills checklist, as we've said. We're identifying that it is just so much more than skills that we want to have a little look at. But it's a watch this space. We will be involving all of the local chapters in part of that as well. And we hope to have some news on that fairly soon as to how that's going to be driven. So what I will do is I'll just open it up to any questions via the chat at the moment, and we'll answer any questions that you have. We've got a bit of typing happening, but I'm just waiting for the questions to come up on the screen at the minute. Just while those questions are coming up, just one other thing I thought of was Megan was identifying that we were using the Dreyfus model as far as novice to expert. And for those that are not familiar with the Dreyfus novel, it is very, very similar to what we would all be used to as far as Benner. But what it's done is it's just defined and differentiated a little bit more each of the elements through from novice, beginner, competent, proficient through to expert. And what it's done is it's looked at knowledge, your standard of work, your autonomy, coping with complexity, and also the perception of the context that you're dealing with as well. Okay, so it just gives, it's a lovely little table, and that's in the competency booklet as well. You know, as far as seeing actions in as part of the longer term goals, or seeing the overall picture and how the individual actions fit within that as well. Yeah, providing alternative approaches to what may be possible. So there are things that people are doing at a more advanced level. And no questions have come up. Has anybody got anything further before we finish? Or would anybody else like to add anything? Okay, here they are. From Christian, like the novice to expert framework, always concerned about competence and accreditation. I think there always needs to be personal responsibility surrounding one's scope of practice. Yeah, I agree with that there needs to be personal responsibility, and certainly that's where we've also brought in about accountability as well, because, you know, it's not only looking at the legal and ethical practice, but it's really your accountability for a lot of that as well. So I think that that does tie in with personal responsibility. And if someone is using this document, it's having a personal responsibility to pick out the elements that they are reflecting on that they need to be furthering themselves with. So that, again, it's getting away from just those minimum standards that we're looking at. But, you know, what is it that I need to be taking that responsibility to drive myself further and improve myself, you know, as an orthopaedic nurse? So that's, you know, one of the things that has underpinned our document as well. Anne-Marie, agree with you. Also heard many anecdotal stories. Orthopaedicians on a general ward missing the specialist care that they deserve. Think that this competency would be invaluable. Yep, and that's one of our big things, is that someone that has actually a physical thing that they could deal with the hospital when they say, you know, when they undervalue the care of having specialist nurses for particular patient groups, is having a document that they can go to and say, well, look, this is what orthopaedic specialty nurses do above and beyond what is expected in a generalist role. And I think that those things are not necessarily valued enough. They're out there in some hospital settings. Decisions are being made by people without experience in orthopaedics to know what it is that we do. And that's why it was just so important to define what we do. And that's where we're moving forward to keep defining that as well, so that we can show that it, you know, we are delivering a higher level of care for those patients. We know those situations that Anne-Marie's talking about. We've all would have anecdotes, definitely, of situations where we know that we could have done that care better, but it's having something formalised as a document to do that. So that was a very big part of our motivation. Okay, so thank you very much, everybody, for joining us tonight. Do encourage your colleagues to view this as well, so that we can get word of the competency framework out there. And just reminding you again, it is available on our ANZONA.net website. So thanks, and we will be in touch also. Thank you.
Thanks, Wendy and Megan. Appreciate it.
Okay, I've just stopped the recording there. I think it's still just going. So thanks, Anne-Marie. Thanks, Chris.